pontification. She is a fellow of the National Postgraduate Medical College of Nigeria, Faculty of Public Health and Community Medicine. Dr. Ejekam is an adjunct faculty at the Center for Infection Control and Patient Safety, CCAPS, at the College of Medicine, University of Lagos, where she teaches postgraduate students at the 3 levels of the Diploma in IPC program. She also teaches at the Africa Center of Excellence for Drug Research, Herbal Medicine Development, and Regulatory Science of the University of Lagos, where she teaches certificate course in pharmacovigilance and Master of Science program in pharmacovigilance. Dr. Ejekam has over 15 years experience in the field of public health, leading and supporting public health programs and research with local and international organizations. She has several peer-reviewed publications in her portfolio. Please permit me welcome Dr. Chioma Ejekam, who will now take us through setting up a hand hygiene program in a healthcare facility. Thank you.
Thank you very much, June, and good afternoon, everyone. I've just put up my picture to see my face, but permit me to turn it off to save my bandwidth. Okay, so I'll be taking us through, I will try to actually take us through setting up hand hygiene program in a healthcare facility, the practical steps. And what I want to achieve today is a lot of us here, I assume, are already working in IPC one way or the other. I know about hand hygiene, but at the end of today, what I hope to achieve is, even if you have to start hand hygiene program today, what are the first things to do after this class? What is the first step? 1, 2, 3, 4, and all that we'll try to do. So I've been given 40 minutes. I'll try as much as possible to see what we can do within that time. So starting off, what is hand hygiene? It's a physical method of removing microorganisms from the hand. It could be in the form of hand washing using soap and water, applying friction within the right agents and within the recommended time to keep the hands clean. Or you could use alcohol-based hand rub or hand sanitizers. And of course, there's surgical hand scrub as well. Why do we want to do? Why the focus on hand hygiene? Sorry, I need to take this off. Up. Oh, Okay, why do we focus on hand hygiene? Because the contaminated hands are the most common means of spreading infectious agents between people. And hand hygiene has been identified as the most important measure to prevent healthcare-associated infections and the spread of antimicrobial resistance. Of course, it's a very globally accepted indicator of key performance in regards to patient safety and quality of healthcare services delivery. But unfortunately, hand hygiene compliance is insufficient across board, with compliance levels as low as 90% in low and middle-income countries. And even in high-income countries where they seem to be doing or advanced with hand hygiene practices, they never really pass 70%. So it's what's focusing on. Now, I need to, before I go into the guiding step, if after this class you want to start step 1, 2, 3, I want to bring our attention to the key focus or the areas that I would need to be covered in the rest of this conversation or this time that I have with you. And we'll be having a lot of repetition around system change, around these 5 elements, but I won't dwell on it here, but it's important it comes up at this time. And this is what is called your multimodal IPC implementation strategies. There are 5 elements that have been widely researched and agreed as focus areas when you want to improve IPC, especially in healthcare settings, okay? There are system change. You need to change, provide necessary things to make IPC work or other programs in IPC programs work specifically in the context of our gathering today, hand hygiene program. You need to train and educate those who need to practice or improve your IPC efforts. You need to monitor and see that things are actually going as planned, provide feedback to improve. We need to set reminders because lots of research have found that healthcare workers tend to think we forget a lot. And you need to communicate, not just to you two, to even people who come into your facility, or other healthcare workers, your stakeholders who are not directly involved in patient care, but part of the health facility management. And of course, you need to institute a culture of safety in that facility, because that's the only way you can sustain what is being done. So just for emphasis, I need you to have this in mind. They are called the 5 elements of, or the 5 multimodal strategies to improve IPC in healthcare facilities. Like I said, I'm going to be speaking more around this towards the end, but it's good you understand this, because the steps and the guide on how to set up hand hygiene, which I'll be taking us through, is actually addressing these core areas. Now, I put up this, it's not for you to actually see, so don't worry if you say that tiny prints. It's just that for those of you probably coming in contact with this today for the first time, most times when you're looking at through resources, which I'll show at the end of the day, this is how you will see the 5 multimodal strategies presented or projected. So in case you're looking at books, when you jam structures or a picture like this, you know you have met the IPC 5 elements of the multimodal strategies key areas. So that's just what I put it up there. Now, this again is a table showing the same 5 elements of the multimodal strategies, questions that guide you into ensuring that you've actually achieved what is expected for each element. Then I won't dwell on this as well. Like I said, I will deal with it towards the end of the slides. Now, let's dive right straight into how do you go about setting up an IPC program? And in this context, hand hygiene program. For every IPC program, there are key 5 sequential steps, cyclical steps, sequential steps in cyclical nature, not parallel, that need to be achieved. Each step builds on the following step builds on the previous step to ensure IPC improvement and ultimately assure sustainability of that program. First of everything is always you must prepare for action, right? You don't want to, if we listen, for those who came in early, spoke about where Professor Shado Gushola was giving her message on Hand Hygiene Day. We talk about collaboration in every aspect of IPC. If you're the only person who knows IPC and your team members are your weakest link, we won't succeed. And I always say, I remind everybody that IPC isn't like what your finance guys are used to, because we all think at healthcare workers that, oh, health is very important, but forgetting that everything is equally important. Your finance guys are looking at other factors beyond your presentation of your health matters. So especially when you're presenting issues around quality and safety, they're not tangible. So I say that cases like that and where IPC falls in, you must have your strong advocacy skills. So going through this, you have the prepare for action, you must have a baseline assessment, you must develop an action plan, you assess the efforts you're making and sustain the program. So I'm going to go through each of these steps. The first step is preparing for action. In preparing for action, you just want to ensure that all the resources, prerequisites that are needed to be in place to address human resource, are there financial resources, existing budget lines for IPC, probably existing, but is not yet used, because if you want to set up a hand hygiene program, you need to tap into such resources. I don't know the makeup of people here, but I am aware something like Ogun State in Nigeria has dedicated budget for IPC. One of the achievements we made during the COVID-19 period, where we made efforts to improve IPC, to build IPC capacity at primary healthcare facilities across African countries, and in Nigeria, Ogun State was one of the states, and we knew that we succeeded in having a dedicated budget line for IPC So if this is existing and you are the person that needs to start up a hand hygiene program in a facility, you need to know if this is existing. If it's not existing, you identify it as a gap. You need to see that these infrastructures are available. Do you have already hand hygiene stations or working? Do you have an IPC team? Do you have regular meetings? Do you have an annual plan? Have there been, do you have any form of data existing or research around potential consequences of poor hand hygiene, related to healthcare-associated infections? Do your IPC team know their roles and responsibilities? But in all this, at this point, I mentioned again collaboration. You can do nothing without the person who is leading your team, either your facility manager, you're working in bigger hospitals, your CMDs, or your champions. So you bring in your advocacy skill here, you speak to them formally, informally, then formally, right? You approach people who you know that if they get on your team to drive your IPC agenda, you will succeed. So you need to bring all these people on board. That is preparing for action. So at the end of the step one of preparing for action, what is it that these are existing checklists actually? I've shared a lot of resources at the end of the class, but these are checklists that will help you know that, okay, I pretty much achieved what I need to achieve in step one. So you would have familiarized yourself with the hand hygiene guideline in healthcare facilities by WHO. Prepare the scripts that you're giving your 5 minutes to pitch in front of your senior management team what you need to say, without being confused or wasting the 5 minutes allotted to you. Make a list of who will be on your team, okay? Investigate your IPC integration possibilities. If you have already existing like AMR program, antimicrobial resistance program, or an IPC team existing, or any form of environmental health programs existing in your facility, you want to integrate it so that you don't fragment your IPC practice. You plan for your meetings, you would have secured verbal commitment from your leadership. So this happens in step one. In step two, you now do your baseline assessment. The core of the rest of what we're going to do will be on this, but here, we've said it at several meetings and everybody knows it right now, that data is the new currency. There's nothing you do without data and evidence, okay? We practice evidence-based medicine and evidence-based practice, and it's all about data. And people will say, we don't already do IPC. There is data to say we don't have the IPC. There are IPC IPCAF tools, but in this context, we have the HSAF tool. HSAF tool is the hand hygiene self-assessment framework. You apply that to your setting, to see that probably you are yet to start, you will score zeros. That is what you use to have a start line. That's your start line. If you make progress, you can go back and see and prove that progress, because the whole idea, remember I mentioned advocacy and knowing that you have to, the business of quality and IPC isn't buy or sell. Buy for $1, sell for $3, and you make $2 change or gain. It doesn't work like that. So most times you have to apply the benefit, right, over time. So your baseline is always very important in anything you want to do. And in this context, we mentioned that you have a hand hygiene HSAF. It's called HSAF, hand hygiene self-assessment framework, which we will dwell more on in the later time part of this presentation. But that's what you use for your baseline assessment. And at the end of that assessment, you would have summarized the findings, analyzed it, presented it to your stakeholders, who will see what has happened, because it's important at any time that you provide feedback of whatever you're doing. So you let them now know, okay, we don't have, or we have a program that is non-functional, or we have a program that is suboptimal. Okay, we're going to dwell on how HSAF is actually structured, and I'll have a makeshift scoring of what it looks like. But this is what happens in stage 2. So at the end, you need to present a report of the findings, and you keep this safe, and then agree on the frequency of your HSAF assessments. The stage 3 is, or the step 3, you now want to develop and execute plans based on the findings of your baseline assessments. At the end of the baseline assessment, you're going to have what are the identified strengths, what are the gaps, okay? What are the actions required for each identified gap area? Who is responsible? What is the timeline of achieving that guideline? And is this particular gap requiring a little of a budget or no budget? And I always suggest, look at your quick wins, look at most priority areas and you can achieve without first asking for large, much or huge amount of resources, okay? So we're going to be applying this to a hand hygiene program, which is, in this context, you want to ensure that there's availability of alcohol-based hand drugs in the point of care, education of, maybe education was what you found that people, your healthcare workers, the last training was probably 5 or 2 years or 3 years ago during the COVID period. They've not been trained again on hand hygiene, and you have new staff on 5 months of hand hygiene. So you need to put that on your plan. When is the training going to happen? Who is going to provide those trainings? So these are the findings of what you get at the end. So you prioritize your actions and complete this action plan, like I mentioned. What are the actions expected based on the strength, the weakness, the gaps identified, who would provide this action, and what is the timeline for this delivery. So I put up just a sample action plan. Why I chose these ones, disregard the fact that I didn't put an action here. What I did here was to pick up a few things just to look at this budget or resources needed. If you don't have an IPC team, you don't necessarily require a budget or funding to set up a team that is existing in your facility. And I always say, when you do this, make sure you leave a good example. Work within your timeline. You don't want to go back to your management and you have put certain it justifies the need for certain funding. And who is responsible? Maybe your IPC lead, senior management, or your CEO. That kind of thing will require funding. So a timeline of 6 months is doable. Imagine that your gap was that your IPC team do not know their roles and responsibilities. So in that kind of required action, you need to who is responsible. That kind of identifier gap does not require any budget. So that's why I put it up there. This is a typical action plan template shared by WHO. You will see it in the resources that I've shared. Most of the IPC manuals have this particular kind of guideline. Again, it addresses what I shared earlier. Now in step 4, we want to evaluate the impact of the program. Remember that in step 1, after step 1, preparing for plan, in step 2, you have to do a baseline assessment to know where you are starting from, so that when you are progressing, you can prove and say it is the effort or the intervention that we have put in that is causing this change. Okay, and how do you now, by the time you develop your plan, your action plan, you need to go and evaluate to see that the action plan improved your baseline assessment. So that's what happens here. And this is the thing here. I just put it, everything I've said now, put it up here. So it means that in step 1, where you have baseline assessment, you will use the HSAF tool, the hand hygiene self-assessment framework tool. And in step 4, you use it through your 5-year plan of your HSAF assessment. Usually we're getting to that, okay? So you now, with the 4th group, you're comparing your finding to your baseline. Did your action plan and interventions carried out, did they improve your data from the baseline? So at the end of the step 4, you expected to have your reviewed action plan based on improvement. We expect improvement. You don't want to waste resources, whether time, human resources, financial resources. Okay, so we expect an improvement on your baseline assessment. It means that your new action plan will be updated. If your staff have been trained, you don't need to put that at least in the next 1 year for the training or in the next 6 months. You print these copies, make them available of your updated evaluation or assessment. Always communicate back to your senior managers, your stakeholders, your champions. At a previous webinar, we have shared how to, for different cadre of healthcare stakeholders, how you project your data or how you communicate your findings. But that's not the essence of this focus today. But to understand that whatever you do, your action plan that is updated, you need to communicate to the guys funding you, your senior managers, allowing you your time to practice IPC. That tells them that your effort is actually generating some benefits. So this is the fifth one, is sustaining the program over the long time, which is all about sustainability plan. Whatever thing you do in a program, what you want to ensure is that beyond you, first of all, every member of your team understands what needs to be done. If you're not there, somebody else can do it. You can't be the only IPC champion. You go on leave, you travel, you change location. And when you go, the IPC dies with the person or phases out with the person. That is not what we want to achieve. So that's what we talk about, collaboration in everything you do. You have every member of your team, IPC experts, IPC practitioners, nurse, doctor, public health people in different parts of your health facility who are champions, or finance guys should be on your team, so that when they see that money is going down, they are the guys that will move the agenda forward. The most social people in your team must be carried along as well. And in sustaining your program, you want to ensure that your leaders are actually your IPC champions as well. So and at the end of the day, you want to repeat this cycle of the 5 in the next 5 years at least, so that this program runs and it becomes an institutional culture. So at the end of the step 5, you would have had an annual review cycle through the IPC committee or the IPC team, develop your 5-year plan, meet your champions, thank them, secure their ongoing support, publicize your findings. Okay, we're going to practicalize this in the next few minutes. Publicize the successes to even the external people during meetings like this, like Dr. Ariyo will be talking after me. Technically, he's going to be sharing with us who are not in his facility the good work, the great work he's doing in his own center. So you must blow your trumpet and let them see, and linking it to science at the end of the day, not talk and no do, talk and do. Present your findings in relation to, look at the data prevalence of HIs in your facility, how your hand hygiene may have influenced or improved or saved somebody's life, share them. So remember that from the beginning, I called our attention to the elements of what I call what is called the 5 elements or focus areas, or the 5 multimodal strategies for improving IPC. And we're bringing it now in context of the hand hygiene program, especially trying to take it through the head staff too, okay? Now, the head staff, as I mentioned, is the hand hygiene self-assessment framework. So I mentioned is a diagnostic tool to assess existing hand hygiene activities and identify strengths and gaps. It has 5 elements across these areas that I mentioned earlier, and there are 27 indicators. And after the assessments, indicators and your scores are summed up, you now allocate and see, are you in the adequate, between inadequate or advanced? And who should feel this? Any IPC professional in the team, you are able to. Every member of the IPC team should be able to. Sorry, somebody is speaking. Your senior manager should be able to do that as well. But certainly, whoever is going to apply a HSAF tool is somebody who understands IPC to some extent. Now, I just took this picture from our ICANN training slides that shows the benefits. What is HSAF used for? How is it beneficial? It could serve as a global best practice quality indicator for hand hygiene. It drives best practices, a hospital practice to assess as a diagnostic tool for agenda setting and all that. That's just what it is. Again, recalling this structure. So the HSAF tool will go through each of these components. Now, I'm reminding us again that using those components, you're going to be seeing the system change in hand hygiene. A system change will require what is the minimum criteria for implementation of system change in hand hygiene program. You need to have the bottles of your alcohol-based hand drops positioned at points of care in each ward. You need your staff, your healthcare workers to have their hand hygiene personal alcohol-based hand drop clipped on their clothes or available to them. And part of hand hygiene system change requires you having hand washing stations at designated and important areas, as particularly it's been advocated 1 in 10 beds should have at least a hand washing station. But I think recently they put it to 1 in 6 beds. But beyond what makes a functional hand hygiene station, you need to have the water, the soap liquid soap preferred, and your fresh towels, okay? Disposable towels are available at every station. You need to ensure that your staff is trained, the staff is trained periodically, okay, on different things. I'm going to come to that. You need to observe. We have mentioned that you must look. If you do everything without evidence seated here, how do we know that you did it? You must look, okay? You must set reminders. Reminders come in form of 5 moments of hand hygiene, how to do hand wash, how to do hand rub, different things that make people, when they see, they know what to do. They're all reminders. And I will share an experience as well in the course of our nationwide assessment of hand hygiene programs across different countries. But I have a beautiful experience from Enugu, and I hope some of my people, my guys are here. You know what you see in banks, okay? Because these guys are innovative. When you come into a bank, let's say GT or Zenith, while you're in the banking hall, you see them flash all the services they provide in the bank, even when you want to listen to while they're showing CNN. So these guys from Enugu, some of the facilities, UNTH guys, orthopedic hospital guys, they know themselves here, Kachi and Chinenye and Co. They have a strategy that they shared with us where they, in the, either the reception or in the wards where people watch TV, CNN and Co, they have flash moments, break periods, like where they flash hand hygiene, in the health facility, just on the screen. So anybody who is watching television at any point in time will see those flash things on how to perform hand hygiene, the 5 moments of hand hygiene. And we found it very interesting and innovative. And that beyond reminders would support even in this step 5, which is institutional safety climate. So again, I mentioned that there will be a lot of repetition around these 5 elements multimodal strategies, because that's the core of what our 5 guiding steps will address. But you must understand this, that system change is about building it. And we talk about health training and education is about teaching it. You want to check, you must observe. If you don't check, you can't measure. You must sell it. You are the champion. Get all the people who need to be to get on board. You will leave it when your CEO and the boss and the facility manager is a champion in IPC. He has the authority to actually sanction and provide rewards for those who are doing well. So taking it one by one for system change in building it, in setting up a hand hygiene program. We've mentioned earlier, you need to have alcohol-based hand drops at the health at each point with the water continuously available. And in the core of having the system change, there are 3 elements that are called there. You have the patient, the healthcare worker, and the point of care, which I'm going to put up as a photo right now, by the way. So these are these different photos of having your alcohol-based hand drop at different points in the health facility, okay? It needs to be accessible. You see here where the health worker has her own in her pocket. It needs to be, different areas where the healthcare worker, the patient, and the health treatment or the health service occurs. You must have your hand hygiene in those facilities, okay? And this concept embraces the need to perform hand hygiene where care delivery takes place. That is what we are speaking about. Then at this point too is beyond alcohol-based hand drop, the hand washing station. It is important to know that multiple use towels is not recommended. You have to have single disposable towels. There are alternatives that have been suggested. People have had different innovative ways. By the way, in IPC, particularly being a member of our team here, innovation is key, okay? That's why you see beautiful pictures of different things. You may not have all the nice, well-built ones here, but we have innovated in Africa and different places. Liquid soaps are preferred. And now, I put this up because this is actually beyond the hospital facility in a very remote area, primary care facility. They have their alcohol-based hand drops at health workers, but they have lots of these in their point of care areas, right? Here, whenever they wash hand, to avoid splash here where you see my cursor, they have an assistant in the health facility who discards this water. So the whole idea, what I'm trying to put up here, not that I'm suggesting you go on this, but the thing is, rather than waiting for all the electronic guided or pedal bins or even non-touch ones, you can innovate based on your local context. Now, again, even on this photo, again, you see the reminders placed here, right? So that's the whole idea. The photo speaks lots of comments. Now, what I'm doing here is I mentioned that when you use the HSAF tool, you have checklists to see that you have fully ticked off the key things that you need to achieve in each of those 5 focus areas. I'm not going to spend time dealing with each of the questions. I mentioned that what I want to achieve at the end of this class is to guide you on the steps which you have mentioned. I've taken us through the 5 steps. Then secondly, the focus areas and how to use your HSAF tool, which you have to go and assess and spend time to read. So while I'm taking you through these points, I'm going to putting up a slide where I've picked some responses, so to bring us into how you assign and take actions, okay? So for this, my makeshift facility, in my system change in the HSAF tool, these are the scores, and the system change for my facility is scored 100 over 100, because for each focus area or section, you score over 100, okay? Now, for the second part of our multimodal strategy for setting up a hand hygiene program, we talked about training and education of the health workers, and that's your teaching it. And we mentioned earlier, I showed you earlier, the patient zone, which is very important. What do you want to teach? You want your health workers to understand the patient zone and the healthcare zone. You need them to understand critical sites, areas, the body fluid sites, and the clean sites. You want to teach them on how to perform hand rubbing. You want to teach them how to perform hand hygiene. And other trainings that you require, you will see that is necessary to advance your hand hygiene program, but these are most basic ones, okay? You want to teach them 5 moments of hand hygiene, which is not the focus of the class today, but this is just a picture and a reminder of what our 5 moments are. And again, just to let us know again that what actually these actions of each of the 5 moments, what it protects, but this is not the focus of the class today. The second area, the training, these are the checklist questions. And in the context or for the purpose of my own makeshift facility, my facility today is called 60 over 100, because some of the questions you want to hear here is, or you see here on the HSAF tool, is WHO guideline on hand hygiene. Do you have, are the following documents, okay, available at your facility? Because what do you want to train them with? Even when we train today, I don't expect you to fully know everything. I'm giving you a guide, a high-level overview. You need to go back and read. So imagine setting up this program in your facility. You need to see that, ensure that the WHO guideline on hand hygiene in healthcare is available, or you produce a summary for your facility. So you respond here, yes or no. And questions like, is there a system in place for training and validation of hand hygiene compliance and observation? Do you have a system in place? You respond, and that is the score for my facility. Now, the next section will assess monitoring and evaluation, which we have talked about checking it. That's the third section of the HSAF tool. Why do you want to monitor hand hygiene? It is the most valid indicator of healthcare workers' behavior related to hand hygiene. It provides feedback information on implementation of your hand hygiene action. By the time you assess and observe hand hygiene amongst workers, you go back, they scored 70% today, you go back and they scored 20%. It shows something is happening, okay? It shows that you're having improvements in your plan. And this is a health senior manager trying to assess the nurses' hand hygiene compliance by direct observation, and this is the observation tool. And these are the questions for you to check off or tick off when you're using the HSAF tool. And for my facility, I scored 75. It asks questions like, do you provide feedback after your compliance? Do your health workers get assessed annually for indications of health hygiene or the technique? Please, somebody's please, can you mute yourself? It's interfering with my talk. Thank you. So now the fourth one is reminders in the workplace. You want to sell it. We spoke about different reminders, 5 moments of hand hygiene for central venous catheter, different 5 moments of hand hygiene focus for different areas. I have here how to hand rub, how to hand wash, and I shared already, you can use even the TVs, you can make short video, how to perform hand hygiene, or remember hand hygiene, the portals of hand hygiene. They can pop up on your TV screens in your reception and in your wards, which we have seen happen amongst our students here in our IPC program, diploma program. And this is the checklist for setting off reminders. It's ask questions like, do your posters explain the correct use of hand rub? How frequently does a systematic audit of these posters occur? So you respond accordingly. Now, the last one is institutional safety climate. You want to live it. You want to ensure the sustainability. You don't want a one-off exercise that does not follow up or build on every success you've achieved. So look at here. It looks like it's even the health, the patient that is assessing the hand of the health worker. But you see, this is probably a CEO talking about hand hygiene even to the clients. These are visitors or the clients in the health facility trying to do their hand hygiene, maybe how to perform hand rub and all that. So here in this institution, everybody, you have your champions, your leaders, who are the people, even can wear lapels to say, I'm an IPC champion. But here, every member of the health facility, from the cleaners to the people in the engineering, the finance team, understand the importance of hand hygiene in your facility. This is where we want everybody to be. And these are some of the questions that you're going to answer. And for my facility, we got 60 over 100. So at the end of using the HSAF tool, what do? You remember I walked you through this course for my facility. So each of them over 100 of the sections, and we got 385. The next step will now be to assign your hand hygiene level in that facility. And according to this category, the 385 falls under the advanced. I chose this advanced for a specific reason, okay? If you're anything before advanced, you now go straight to your development of your action plan. But if you fall within the advanced, okay, this is again what tells you the interpretation of any level. If you're inadequate, it means that significant improvement is required. If your facility is intermediate, it means that health promotion of hand hygiene promotion is in place, but requires improvement. If you're advanced, it means that you have the hand hygiene safety culture embedded, but need to now apply leadership to other places around you and ensure the sustainability, at least over a 5-year period, that can be reviewed afterwards. So I chose advanced for a reason. If my facility is advanced in this context, our facility is advanced, you now have the next level where you fill in the leadership section and it asks you questions. For you to truly be at the leadership level, you should answer at least yes in every, at least in 1 yes in all sections. And in this contest we did, so that means our facility has reached hand hygiene leadership level. So in summary, this is a summary of the HSAF tool. You tick off your checklist for each of the 5 components, summarize your score against 100, complete it and assign your facility level, and draw up your action plan. This is a pictorial aspect of what I just shared here, how you add up your points. But very importantly, every effort is to develop and execute an action plan, okay? You need to develop, that's actually what guides your going through this cycle the second time. That forms your baseline. That shows you if you're making improvements or not. And this is how a picture of what your action plan will look like at the end of your HSAF assessment. Again, coming through your components, you want to always start from strengths. We always tell, especially in IPC, you don't start with what is wrong, everything is wrong, even when it's not existing. The fact that your IPC champions gave you the opportunity to come and speak to them, please identify that as a strength, meaning that the IPC leadership have interest in improving IPC. So blow their trumpet, see that as a strength. Oh, there's meant to be 100 or 10 hand hygiene stations, okay? But there's only one. Always celebrate that strength, that, okay, we have 1, but we need to have 10. Okay, so you identify your strengths and now get on your, you identify the strengths, list out the strengths, then now move to your gaps, okay? Certainly, we talked about, if you remembered, on the steps of IPC program implementation. The fourth talks about evaluation, and certainly the ultimate output of evaluation is to track progress. Actions, are they improving your baseline output? Okay, so this is a good example. When you did the first one, you were at inadequate. It's expected that by year one, because most times the HSAF tool recommendation is for it to be done annually, but you can do 6 monthly, okay? So I'd expect you that in the next round of your assessment, you should be on basic, you shouldn't remain on adequate, but you need to have this table to track your progress. These are the things to share with your funders, your senior management team, your IPC champions when you have meetings. So in conclusion, hand hygiene is the single most important method to prevent the spread of infectious diseases. The 5 elements of the multimodal strategies, which I repeated over and over, are necessary for successful and sustainable IPC improvement. They are the core focus areas, which has been found to, if you need to improve IPC, and in the context of hand hygiene program, you must address those areas. And we spoke about the 5 steps that address those areas, which are your preparing for action. You don't just appear and start setting up IPC, alcohol-based hand rubbing stations and all that. You must prepare. Okay, that way you're getting your buy-in, you're getting participation, you're getting endorsement before you get on your journey. And we finally had an overview of the HSAF tool, which is the core tool that is validated, that will guide your assessments of the hand hygiene program, which you have set up or you're about to set up. That means you have a baseline, but the HSAF tool is the tool for assessment and subsequent monitoring of hand hygiene programs. So these are the resources that are available. Everything I've shared here, the templates and all that, you can get them from here. You can do a screenshot, you assess them. And like I mentioned, this is to get you to where to start. After this meeting, you want to start program. What do I do? Step 1, step 2, step 3. And what do I look out for? But for you to have absolute understanding, you need to read a little more. So thank you for listening, and I'm happy I made it at 40 minutes. Thank you, and I understand we're going to have questions at the end of Dr. Ariyo's presentation. So put down your questions for me, and again, thank you for listening. Over to you, Dr. Ejembi.
Thank you so much, Dr. Chioma Ejekam. I'm sure those of you that we are online, when I read her citation, can see that it was well justified. Please, can we give her reactions? Those of you that can clap, those of you that can send thumbs up or whatever it is you felt about the presentation. Let's have reactions. Oh, we don't have reactions on this. Let's unmute and give her a good round of applause.
Thank you. We need to move on. Thanks.
So I think we will let the second speaker, go on before we take our comments and questions at the end. So thank you all for joining so far. Please permit me to present to you Dr. Olumuyiwa Ariyo, who is a consultant ID physician at Federal Teaching Hospital, Ido-Ekiti, Ekiti State. He's also a graduate of the Diploma in Infection Prevention and Control that is currently being run by the College of Medicine, University of Lagos. Please, let's have Dr. Ariyo, who will be sharing his facility experience with us. Thank you, and over.
Thank you so much, Ma. Can I share my slide, or will it be shared at your end, and permit me to put off my video so as to reduce my bandwidth?
Okay,
Ma,
please.
do I share my slide myself, or to be shared from your end, Ma?
Which do you prefer? If you want Mr. Lekon to share for you, he can do that. But if you want to share from your end, that's fine.
I think Mr. Lekon can share for me. I think that would be better instead of me looking for that. Mr.
All
Lekon,
right. Mr. Lekon, please.
Okay, just a moment.
So while Mr. Lekon is trying to do that, I would like to acknowledge everyone on this call, and I appreciate NSIC for putting this together as we try to make effort to improve IPC practices in our dear country and the continent of Africa. And I have that confidence. Many of my teachers are here at the diploma course at the College of Medicine, University of Lagos. So I know I'm standing on their shoulders to actually discuss how far we've actually made some improvement, especially at the last 6 years, although more over the last 3 years when COVID-19 came in late 2019, 2020. So what are some of the progress that have been made in infection prevention and control in our Federal Teaching Hospital, Ido-Ekiti? I think also on this call is our infection control nurse, Mrs. Ajoke. I would like to also acknowledge our presence here. So over the next 10 minutes, I will just discuss that. Sir, you may move to the next slide, please. This is our hospital, Federal Teaching Hospital, Ido-Ekiti. It's a rural teaching hospital in Ido-Ekiti, Ido-Ekiti local government in Ekiti State. So it's a multi-specialty hospital. It has about 250 beds. It was established in 1999, about 24 years old now. I will say that, next slide. Okay, our IPC program, I will say really kick off. That was in 2017. We had a case of a student nurse that had confirmed Lassa fever infection then. And I think that actually spurred the management into action to really set up an infection control unit. And an infection prevention and control committee was also set up. And it was headed by Dr. Uyekale, consultant medical microbiologist. Other team members include infection control nurse, of which Mrs. Awutono is leading, myself, pharmacists, medical lab scientists, and the likes. And ever since then, effort has been put in place to really see how we can really improve infection prevention and control practices in our hospital. So I'm providing a kind of a synopsis of what has been done so far. Next. So Dr. Ejekam, my teacher, has actually, provided a beautiful presentation on how to actually, setting up an hygiene program or improvement in our facility. So in our facility too, we try to do that. And that was even part of our project to complete the DIPC program. So my facility, we've been making effort to ensure sustainability of production of alcohol-based hand rub, although there are some hiccups at times. And we want to ensure that as much as possible, this is available at a point of care. Then the availability of water and soap, as much as possible, also at the access for healthcare workers, so as to reduce healthcare-associated infection. So one of the things that we try to do is to ensure that, okay, alcohol-based hand rub is available at a point of care. Then we also incorporate our training. For example, in my facility, I think 2 of us have attended the DIPC program in Lagos. About 4 personnel too has also attended the UCH training. We try to also see how our staff has been compliant with observing and hygiene. That was part of the thing that was actually done during the DIPC project. And for the use of soap and water, we, apart from those sinks that are available on the ward, especially some of them have been complemented with the Veronica bucket and some pedal control bucket to ensure that especially all those high-risk areas, for example, our neonatal or newborn unit, NICU, has improved. Some of these things were not that popular, as it were, over the last 3 years, but we've seen a lot of improvements, and part of these include some of the advocacy, and I think permit me to mention NCDC too, led by our pillar, led by Dr. Toshi. Next. Okay, waste management. Here on the right side, no, I think this our incinerator was procured, I think about 3 years ago. So we did not have that. before. So apart from sorting waste at a point of generation as much as possible, at least we are segregation. We now ensure that our waste are properly incinerated, and chap buses are provided. The incineration of our waste is a PPP arrangement between the hospital and a contractor. So majorly, the incineration process is what is actually taken over by the private venture, while color-coded liners and bins as much as possible has been provided to actually ensure that waste generated in the hospital are properly disposed. Next. This was established, our infectious disease ward. We actually name our own not isolation ward because it's not just for isolating patients. There are some inpatient we are looking at a feature that is much more bigger than isolating patient, performing many functions as a unit on its own. So we have our infectious disease ward established late 2021, early 2022. And currently we have some patients on the ward. It's a 20 beds ward, 10 for male, 10 for female. And we have a hair filter to ensure that negative air pressure is generated. And we have some of our facilities, like for example, if we need a patient that needs to be intubated, we don't need to transfer our patient to the main ICU of the hospital. So many other things are actually done in our infectious disease ward. Next. And this is our molecular laboratory. This was also established, and it has greatly helped us in actually making diagnosis on time, because over the years, one of the things that has really challenged us in our facility earlier is getting diagnosis early. I remember there was a time we need to send sample to Irua if we have any suspected Lassa fever. Although we do not have capacity to still do Lassa fever screening yet, however, efforts are in pipeline to actually get the primer and the cartridge. Since we have the thymocycline, we have two thymocycline in our molecular laboratory to actually diagnose Lassa fever. Currently, we have 4 suspected cases. The samples were taken yesterday, and we actually spoke with our state epidemiologist yesterday now, so that we can actually get this. But we know that early diagnosis has a lot to do, aside isolating patients, has a lot to do with managing, preventing infection, and actually controlling infection. So currently, our molecular lab can actually do PCR for SARS-CoV-2, can test for HPV DNA, and facility for HPV screening and diagnosis is also available and is being installed. What we are working on is to actually expand this to ensure that as much as possible, we can actually diagnose all this infection and actually intervene as early as possible. And another good thing in our state is the fact that we now have an NCDC reference laboratory, which we believe will collaborate with our hospital to actually improve infection control generally. Next. Okay, before I go presentation. Hello, please, am I audible? Hello?
Yes.
Okay.
Sure.
Yes. Another aspect that I would love to talk about is our CSSD. And I remember during our program, one of the assignments that was given to us is to actually see how to even improve our CSSD and our laundry. And I think over the years, too, some effort has been gone into this to actually see how to improve. I will say this, and that will lead me to some of these barriers or challenges. There are many, but I intentionally put these 3. We know that the culture or the belief as regard IPC, generally, many people still have that approach to IPC as outbreak response. I mean, if there is a confirmed case of, let's say, an outbreak-prone disease now, that is, but the routine day-to-day or building system, there are still some issue with that. Although we have a very supportive management that has been, making efforts. And I will say this, especially at our advanced program, a lot of skills that our teachers, some of them that are here, actually taught us, really help in actually getting management buy-in. Although we still have some financial constraints, not just availability of money, but the protocol or bureaucracy of getting fund release as having some hiccups, and that has actually hindered at times some of the things that could have been done as regard IPC program. And I will say this, the second point, low hand hygiene compliance among healthcare workers. It is still a lot of issue as regard compliance rate with hand hygiene among healthcare workers. Doctors, nurses, health assistants, especially those are the three people that are actually closest to the to patients. Although we know that with more intervention vis-a-vis HIC material and some of all those other things that Dr. Ejekam has actually said, we believe this will improve. And the good thing is that some of these things has improved, but we know we have not gotten to where we really desire. And lastly, healthcare worker behavior. There is another issue because many people still see IPC as if it's a thorn in the flesh or is a disturbance as well. But we know that with time, some of these things will actually improve vis-a-vis some of the things that we are being taught on this platform, NSIC, the DIPC, and the likes. And we know that IPC, my facility in Nigeria or in Africa, will still improve with time. And lastly, just to conclude, I will say this, that over the last 6 years, IPC program at the Federal Teaching Hospital Ido-Ekiti has improved, although we know we have not arrived at the Eldorado that is desired vis-a-vis the different components of infection prevention and control program. But we know that we've made some appreciable improvements, and thanks to some of the platforms that we have to get some training so that we can implement some of these changes. And for me, if I project over the next 3-5 years, we believe we are still going to actually improve further so that IPC practice can fully be institutionalized and patient safety, healthcare worker safety, and the community safety will be improved overall. Thank you so much, Sir Sama. Over.
Thank you very much, Dr. Olumuyiwa Ariyo, our ID consultant, for sharing that beautiful facility experience. We can see how real it is. It brings to bear, it brings to fore the real picture of IPC. You can't have IPC without talking about your challenges that you are facing in trying to ensure that you reach the pinnacle, as we have said. So please, can we give him our reactions as we appreciated his presentation? Somebody says you are a correct IPC guy. Well done, Dr. Ariyo. So that's the feeling from the house. So let's give him a round of applause. So thank you very much. So now we have the floor open for comments, for questions, for any clarifications that are needed. And please, could we have people that are willing to ask questions, raise their Could we have people raise their hands so we'll know who and who we are meeting while I go through the chat to see what questions have already been pasted there? Thank you once again. And while we are doing that, can we fill the poll questions that were sent to our emails alongside the invite for this session? No, my network took me off a couple of times, but currently I can't see questions in the chats. So do we have hands? I can see Daniel Igwe.
Okay. Good afternoon, all.
Good afternoon. Please, let's be brief and clear.
Okay.
So I can give that to others.
Thank you, Dr. Ariyo, for that wonderful presentation, and to our chief who had presented earlier. I was just looking at the challenges you put forward in your last slide in terms of financial constraint and low hand hygiene, compliance amongst the healthcare workers. And I was like, you noted these challenges. Were there any way you tried to, any plan in terms of mitigating those challenges? And then secondly is the low compliance among healthcare workers. Was there any way you tried to find out what led to the low compliance? Was it because the hand hygiene alcohol-based hand rub were not there, or no water, or any other challenges, or their own not being comfortable with whatever alcohol-based hand rub that may have been provided to them? So, or is it that there isn't that frequent reminding them, because of the way we behave in this part of the world, that we would always want someone to pushing us, to monitoring us, and to ensuring that we do the proper thing. So thank you very much.
Thank you, Daniel. Can we have Abiodun and Omar's questions so they can address both questions at once?
All right, thank you, Dr. Ariyo. Thank you, Dr. Ejekam. It was really great presentation. But my question is mainly to Dr. Ariyo. So I'm interested in how you were able to sustain the AVHR supply in the entire facility. You said you're doing locally produced AVHR. So how are you able to sustain that? What the period of time you have began this project? And then number two, I believe your hand hygiene project is facility wide. I want to know if you do monitoring in the laboratory, and what's the compliance rate like in the laboratory, and if the MedLab scientists use repeated glove, use one glove for multiple patients. If that is true, how are you able to tackle that in your facility? Thank you.
In addition to what you've been asked, Dr. Ariyo, there's a question here which says, what is the reason for low compliance? Is it behavior, availability of resources? So I think you can address your questions now. Thank you.
Okay, thank you, Ma, and thank you for the questions. Yes, as regard the low compliance, I would say it is multifactorial, and I will also provide this caveat. Across different units or departments, the compliance is not the same. For example, the ICU and newborn units, we notice that it is higher than most other wards, especially something like medical ward or general ward. So one of the challenges that we've noticed is that due to supply chain, at times we notice interruption in this supply of hand hygiene materials. And actually that's a big headache because, like I said, although we try to see how we can overlap before we exhaust material, but at times we discover that some things are out of the unit control, infection unit control. So that is one factor. Then another factor which we don't have control over is that, especially in ward like medical surgical ward, is healthcare worker attitude. And one of the things that we are projecting that we may need to do, we need to actually also see what's conducting assessment to really see what is their own view or some barrier. Maybe some barriers are peculiar to us. And I will say this, another major challenge, although I didn't want to mention this, but let me just mention it. At times we have water challenges in facilities. For example, now I noticed in my facility there was a particular time some construction were taking place and it affects some water supply. So at times, even beyond healthcare worker attitude or something like that, at times when we have interruption of water supply, so that will actually also affect this compliance. So it's actually multifactorial. Some of them are being tackled. We know we can't tackle everything at the same time. But overall, if we look at where we were some years ago to where we are now, I will have shared some of these data, but I didn't have the permission of my management to share some of these data. That's why I'm not actually giving us some of this data. So that is about the hand hygiene compliance rate. I hope I'm able to answer those people that ask that question satisfactorily. And if there's any area, I can go further on that. Then the other question was on, okay, yes, I've partly answered that Dr. Igwe's question as regards some of the things that were being done to actually see how we can actually improve that. I think I've forgotten the third question, Nama.
So in terms of what are you doing about the challenges you've noted? And thanks for the ones you.
Okay, for example, I think a few weeks ago, I wrote to the management on some of these, and I'm trying to seek an audience to actually see how we can actually address some of them. For example, one of the things that we know could have actually helped us to circumvent some of the bureaucratic processes, that if we could have a direct communication, for example, infection control unit straight to the management, I mean to the CMD, instead of passing, for example, we know that there are some hospital units that are directly under the CMD. So we are looking at, okay, can we place our infection control like that, whereby there is a direct communication straight to the CMD, although we are still negotiating on that. We have not gotten that approval. We know that will actually also facilitate some intervention as regards following through the normal bureaucratic process in the civil side. We believe that will actually also bridge a lot of gap that we are experiencing now. I would say this overall, we still have a lot of things to really do in our facility as regards IPC, but considering where we started before and considering the contribution, I believe we've made some steps, but a major issue is actually those materials. Because at times, I remember there was a particular time, maybe late last year, due to challenges with water. So at that time, we noticed that it was a serious issue as regard having water supply. Although our core base hand drop that were provided, there are some interruption. So at times you could see that we took that assessment, when those materials are available, you see a lot of improvement. However, like I said earlier, NICU, ICU, especially maybe because of the orientation of the staff there too, they have higher compliance as regard surgical or medical wards.
Thank you, Dr. Ariyo. Please, can you unmute Dr. Chioma Ejekam? I think she has something to add.
Okay, I'm unmuted actually, since yet to get questions and Dr. Ariyo is on the hotspot. Let me ask, I don't know, questions or maybe comments. I think and kind of it would have answered a lot of questions too that Dr. Daniel Igwe and other people have asked, but I take it that he made a comment that his facility didn't get permission to share data, but I imagine that if the presentation went the route of even if he's giving a high level kind of summary on those components because of system change, you know, the training and education, the 5 multimodal strategies, right? Monitoring, and you leave it and you check it and leave it, right? So if you, Dr. Ariyo, I'm thinking if you made it that way, even if it's not giving us specific summary to say, oh, we are scoring 10 out of 100 or we're scoring 9 out of 100, it will give us a more, I would have loved to actually say that that's where I'm going to it would have answered a lot of questions that are coming up and will give us a more practical thing, you know, at a glance, without speaking so much on where you were, especially where you started, because I hear you say things like, you believe that with this and that, and remember this is science, okay? We need to see that, okay, you are here, we're moving to the next level, these are the possible challenges, or why the challenge with progressing, like the behavior part, the availability of the alcohol-based hand drops and all that. But I'm suggesting and I'm thinking that it would have been good if we use that to make this at a glance, somebody will understand where you were actually and how 3 or 4 years after, which component is actually struggling a bit, okay, and all those challenges. So this is probably a question or now a comment as well. Yeah, over.
Thank you very much, Dr. Ejekam, for that contribution. I think what I also want to say, in addition to those that asked questions regarding Dr. Ariyo's presentation, was the fact that if we followed Dr. Ejekam's presentation, especially when she gave us the ABC of setting up a hand hygiene program, it will make it easy for us to know what challenges we have and what we have done to address the challenges. And then when we repeat our assessments, we can see how well we have improved. We all know that when it comes to convincing hospital management, just as Dr. Chioma has stressed, we need what? Data. And as she said, this is the time for data. They say what? the gold mine that we all have now is data. So when we are doing our baseline,
data is
the new currency
everywhere beyond health sector. Yeah,
it's everywhere. Data is a new currency. So if we have done our baseline assessments, we have engaged all the important stakeholders, and we now find out where we are lacking. So even with minimal resources, we can improve our IPC programs. And one thing that came out very clearly in her presentation is the fact that we have to develop an implementation, develop an action plan, which we will now implement, because following your plan helps you know how well your progress is, and that enables you ensure that you are keeping to track. Because I can tell you, most of us, it's not only IPC we do many other things. So without the implementation plan to keep you on track, you keep going back and forth. Then of course, the emphasis again on what? Assessing what you have done and repeating, sustaining the program, and then repeating the cycle over again, because it goes beyond a knee-jerk response. Dr. Ariyo mentioned the fact that people think IPC is only about outbreak response. No. When a facility has a good IPC program in place, it helps to reduce HEI, healthcare worker infection, patient infection rates, and improve the quality of care that patients receive overall in the healthcare facility. So do we have any more hands up or any other questions?
My hand is up. I just want to add to Dr. Do I have the floor?
Ma, you do. Yes, Ma, you do.
Yeah, I just want to add to your comments and Dr. Ejekam's reaction. I want to thank the two presenters. Very great presentation, very great effort, especially the practical aspect. But what I want to just add, aside what has been mentioned, I know a lot of us are asking questions, but I'm sure some of us on this call have the same type of challenges. If somehow you've been able to resolve your challenges, to be nice to share. This is a forum to learn from each other, because this is learning from each other. And I want to commend Dr. Ariyo, because he has brought in the infection control nurse. I want to commend this, because I think this is a very good effort, and she's listening, so that when they go back to Ido-Ekiti, they will know how to pay advocacy to the management and make sure they move from where they are. But from Dr. Ejekam's presentation, where I know we didn't hear that they did a baseline, or they are not allowed to share their data, but usually when you have a baseline, and then you do your audits, then you'll be able to put some figures to it. It will encourage management to put in more, like everybody has said. But we're all listening, we should know where we should approach things. If we haven't been doing it, it's good to make it your currency. Like using Dr. Ejekam's language, data is a currency we should all be using, and we should take that. That should be a take-home message from this presentation. Thank you, over and out.
Thank you very much. Please, for those who haven't filled the session poll, kindly check the chat and do that. So do we have other people that want to share experiences, how they have overcome challenges in their own facilities? We have 2 to 3 minutes to do that before we round up for the day. Yes, I can see Daniel Igwe's hand is up. Please kindly unmute.
Yes, thank you very much. Actually, we in Ebonyi, that's Federal Teaching Hospital, Abakaliki. We got more or less our inspiration and the push from our last program we did with Prof. You know, so we came down and we first of all started like, how do we start? Where do we start? And who are those to work with us? And also, how do we get the management involved? And that was actually what we did. We got to selected some special areas of interest, because we can't start everything once. We just wanted to have some areas to start off, and then that will give us the boost our morale and as well to encourage the management. So we selected some wards: ICU, newborn, part of O&G, part of pediatrics as well. So and we started off, and then of course before then we had reached management. We wrote them and everything, and then intimating them what we wanted to do. Same thing with the infection control committee as a whole. So we also went to those wards. We wrote the management of those wards, the head of units, the nurses, and all that. And then the matrons in charge of those wards were the ones that gave us the names of those, because we asked them, we needed some names that we want to use as IPC champions, that would be like partners with us in your wards to ensuring that we get this entrenched in your units and wards. They gave, and we just said, you don't just give us anybody. This is not politics, and there isn't anything we are doing here that is personal. We wanted people who are committed to issues of IPC, infection control, hand hygiene, and all that, people who are interested. So, and they did, and we had a meeting with them. We intimated them, we trained them, co-opted MSF in the training, so, and after which they were so happy, and we created a platform, our IPC, because initially we had a platform for just few of us, like myself, Benson, Mike, and we brought them into that platform. So everything we're doing, we're updating them, and all that. So then after that training, they were like, we just hope that this is not, you people have not come to hit and run, And we said, no, we are here, we mean business, and we're going to spend our money to ensuring that at least we start from here, the little we could. So, and that was actually what we did. Even though management supported us, MSF also supported us in a way, and we spent our money as well, So we first provided them with alcohol-based and our personal ones. We bought ourselves, and also the ones management at the end of the day provided us. So, and some other things we needed as well. Some areas needed some fixing of hand washing area, sinks, and all that, which of course management was able to come in a way, not really what we needed, but we just didn't allow that to discourage us. So, and we moved on. So, and then, so that was how the summary of what we did in Ebonyi. And then till today, we still continued, even though that we're still having that challenges of sometimes we don't have it, because management is not every time they keep for coming with the demands. But the infection control unit also tries to, we try as well to produce our own as well and ensure that they are provided at those areas of concern as well. So, and then today we also have some feedbacks from some of them, like sometimes I will get to ICU, get to meet with the nurses, and then they would also want to would start giving me their challenges. We have not had this, we have not had that. And effort will always be made, to providing them with as much as we can. So thank you very much.
Thank you very much, Daniel, for that wonderful experience sharing. I can see you're a very wise man, as follows your name, because I like what you said, the way you approached it. It's very important when you are doing your preparing for action to using your available resources. Can you go facility wide, or will you pick little units? And then when you consolidate your success story there, you can now expand that to the whole facility. So if, for instance, you do not have enough personnel or you do not have enough material resources, just as Daniel did, you might decide to start in some units. Then when you now have a success story to share with the management, which can help you also bring in management buy-in and management support and even external funding, then you can now share and publicize your efforts and your success story, as Dr. Chioma had shown in her own presentation. So please, if we can check the chat, we will see the link for the post-session review to help us improve our sessions and make you feel better when next you attend a session. So while that is going on, I think we can ask Dr. Ejekam to give us her last words on today's session. And after that, Dr. Ariyo.
Okay, thank you once again. And it's always interesting and an honor to share my little knowledge and experience with this team. And I'm happy a lot of my friends here are here, almost everybody here. So one thing that I want you to take away in everything we've said is first, I loved Dr. Daniel's summary. We are here nicely to get into the planning, because that's what we want to achieve here. A lot of people here, people I'm familiar with, and we have that challenge even during completing the IP, the diploma course, even post 6 months of doing this hand hygiene assessment. I mean, setting up the program in your facility. Struggle, we go for assessments, and the challenges persist. Hence my acceptance to present this today, to make it as simple as possible. If there's anything to remember, is to remember your 5 steps of if you want to implement any IPC program. And in the context of today, what is it? You prepare for your action, you do your baseline. From your baseline, what comes out of your baseline, you need to develop an action plan. Then you need to implement that action plan. You need to go back and evaluate what the practice is, or what has happened, to ensure and to see the effect of your action plan, or the action plan, to see the effects on the baseline assessment finding. And certainly this cycle needs to go on and on. Somebody mentioned it's not a knee-jerk approach. Someone mentioned it's not a hit and run thing. Whatever you do should outlive you. Whatever you do must be a skill that should be shared amongst every member of your team. Everybody coming on board, because it's an institutional culture, can just feed into the wagon of what is good. Now, these steps, what does it want to address? Is addressing the 5 multimodal strategies. Okay, you know your multimodal strategies, your system change, your training and evaluation, your reminders in the workplace, or institutional safety culture, climate. Okay, so these 5, everything about those steps is addressing this area, because in this area, even if you're doing an environmental health program and all that within your IPC, it is this same thing. Look at how do you apply change the system. Things must be in place. Even if you train the best people and all that, and you do not have your buy-in from your top management, you do not have these little quick wins available before you now ask for the big money, it won't work. So bring on your advocacy skills. A lot of you do the diploma course here. When I take courses on the monitoring and evaluation, we talk about at the advanced level, we speak about advocacy and IPC. You bring them on, you get your champions. They don't have to be IPC core people. They don't have to be epidemiologists. Get these people to be your core team. What I mean, the IPC practitioners. But for your community, you need even the most social person in your facility, the guys that are very close to the manager, the top management, the finance people. They should drive your agenda. Get everybody on board. Inform them. Okay, whatever is existing, there are outbreaks in your facility. Just as Dr. Ariyo mentioned what spurred them into setting up this IPC committee in their facility for the first time. Share all that, have that information, present it. They're all part of the data. Even when you haven't started, do a baseline that will be a 0. That is a starting point. That way you can prove that I just brought alcohol baseline drop. It now provided this change, right? Even when you may not be permitted to give numbers, we score 7 out of 100, just mention, have that template, because it gives a high level picture or guided summary of what is happening. In system change, oh, we do not have alcohol-based hand rub, we do not have hand washing stations, we only have 1 ratio to 10 beds. That way, you haven't given us your score, but we can have an idea what your challenges are. By the way, remember, you start from your strength. Oh, we have 1 hand hygiene station to 20 beds, but we are aiming to get 1 to 6 beds or 10 beds without giving scores. That gives you your summary, right? And you now go to your gap. Who is going to do what? What is the timeline? For your finance guys and your top management people, they want to see figures. Would this require funding? No, start with the ones that won't require funding so that they see, okay, you can do these things. Then you bring the low ones, then you go for the high ones. So that would be my summary of everything in a nutshell, what I presented today. And I hope it helps us to improve better on our hand hygiene programs for those who already have one existing, and those who haven't yet can actually get started, because it's actually simple to get started. Then everything falls into place. Thank you, and over.
Thank you so much, Dr. Ejekam. I think anybody who listened to your presentation will totally agree with me that you broke down implementing the hand hygiene programs. For anyone who had challenges that attended this session, I'm sure all your gray areas has been sorted out. So, Dr. Ariyo, can we have your final comments before we wrap up? Dr. Ariyo, I saw your chat that you're having network challenges earlier. Are you still with us?
It has challenges, so we can.
Okay. Okay, anyway, he had a lot of responses from his presentation, because as we see, you can't practice IPC and not have a lot of challenges thrown at you. The importance is what setting up a program, because with a program, you can have something that is sustainable and enable you to address your challenges using the multimodal strategies. Because when it comes to changing human behavior, one technique doesn't work. You have to use many strategies together, which is why we have the WHO multimodal strategies to enable us ensure that we can achieve behavioral change, we can have system change, we can have all the structures in place to enable us achieve our goal. I would like to ask Dr. Shewande, do you have any last words for today's session? Hello. So, well, maybe she's also having some network challenges. So I would like to say at this point, please remember to fill the post-session feedback. Thank you, everyone, our wonderful IPs enthusiasts.